Good afternoon, everyone. Thank you for joining us for the webinar on a project we've been working on for several years called Access to Treatment, Bringing NIATX to Corrections. This project was really a joint effort, and we'd like to thank the partnerships that we've had throughout this process. The Bureau of Justice Assistance as a part of the Department of Justice, has funded this project, and Danica Binkley has been a great supporter of this project throughout the years and has really helped to make these products what they are. We also partnered with NIATX to bring their process improvement model to corrections. And then for the second piece of work as a part of this project, we worked with Faye Taxman from George Mason University Center for Advancing Correctional Excellence to develop process measures at the interface of behavioral health and criminal justice. So on the webinar today, we'll talk about each of those products, which are also available on our website. In the chat box, you'll see a link to the first product on the pilot sites. So speaking on the webinar today, I am Sarah Wurzberg, the Grantee Technical Assistance Manager for Behavioral Health from the Council of State Governments Justice Center. We also have Kim Johnson, who is the co-director of the ATCC Network Coordinating Office and the Deputy Director of NIATX. We also have Faye Taxman, who is the University Professor for Criminology, Law, and Society Program and the Director of the Center of Advancing Correctional Excellence at George Mason University. So to begin with, we'll have Kim talk a little bit about the NIATX Process Improvement Model. Then I will discuss the lessons learned from the 3 pilot sites, and Faye will then discuss the process measures at the interface of criminal justice and behavioral health. So the Council of State Governments Justice Center, we're a bipartisan policy solution organization dedicated to serving all 3 branches of government. In the Justice Center, we specifically work with criminal justice policies. We have newsletters which you can subscribe to on our website. This is a picture of our website. And we have one for behavioral health and also one for reentry. And you can also, this is how you actually sign up for the updates. And you can also follow us on Twitter. So there's been a number of tweets about this webinar, and NIATX and corrections at George Mason University are also available via Twitter. So then after we have the 3 presentations, we'll go into the questions and answers. To begin with, I'll turn it over to Kim Johnson to talk about the NIATX model and its impact.
Thanks, Sarah. You can go to the next slide. So these questions are asked tongue-in-cheek. Since you can't see me, I just want to make sure that you understand that. And so why is it so hard for people in the justice system to have successful community reentry? I'm sure people have thought all of these things at some point in time. They're just bad people. It's impossible to rehabilitate them. They're addicts and they just can't help themselves. Or maybe it's the community providers, that they're just useless and they don't follow through and we can't get them to do anything right. So we can go to the next slide. We probably have all, in moments of frustration, thought any of those things. But Dr. Deming, who was a statistician from Iowa, who did his work relatively early in the last century. He did a lot of work actually in Japan after World War II. He had a whole different worldview about what the cause of problems are. And this is his quote. He says 85% of problems that organizations, any kind of organizations have in serving customers are caused by their processes. Now the funny story is he actually originally said caused by management, but that didn't go over very well when he started hiring himself out as a management consultant. And so he changed his language a little bit. But he basically, he has a really interesting book. It's not a very easy read, but he really, he didn't blame people for anything. Well, I guess 15% of problems he would say are individual cause, people cause them, individuals cause them, but 85% of problems that organizations have are caused by their processes. They're caused by what we do, and how we do things as opposed to who's doing them. Okay, next slide. So in order to fix a problem, in order to improve reentry processes, we need to fix the processes. So people in the justice system are served by processes. Now, they are served by people, but the people do a process. And what Dr. Deming would say is that the people, the staff, are doing the best they can with the system that we gave them to work in, and that the vast majority, 85% of problems, are caused by processes. And so if you really want to fix problems, you have to focus on processes. And this idea of process improvement, fixing the process as opposed to changing people or trying to get people to be different, all of this stuff came from Dr. Deming's work. So so NIATX is one model of process improvement, and I'm going to talk about that. That's the one I know the best. But if you've heard of TQM or Lean or Six Sigma, those are all process improvement models, and they all originate in the work from Dr. Deming. And he actually is the person that went to Japan and helped them reconstruct Japan after World War II. And the auto industry in Japan really adopted his ideas. And so, I don't know, maybe 10 years ago when the Toyota model was a really popular thing, that really came from this statistician from Iowa, even though it was made popular in Japan. Okay, next slide. So NIATX is built on process improvement. I should say that what NIATX is, it used to stand for the Network for the Improvement of Addiction Treatment. We have worked so much in so many other industries now that we just say NIATX. We don't really say Network for the Improvement of Addiction Treatment, except for when I'm talking about the history. NIATX, we live in a Department of Industrial Engineering at the University of Wisconsin. So we come out of that systems engineering background, although I personally am not an engineer, although all the rest of the scientists here are. And so that really is how we think about things. We don't look at people and personalities and culture per se. We look at how things are done. Dave Gustafson, who founded NIATX, did a meta-analysis. The paper was published in 1995, where he looked at what are the elements that are most important in any successful change, any successful process improvement, regardless of what the industry is. And they came up with a list, he and his co-authors came up with a list of 80 items in different research that they found in different research papers around systems improvement across different industries, so healthcare, manufacturing, it didn't matter what industry, they looked across all industries. And what they found was that there were really 5 things that were almost universal in successful change or successful systems improvement. And it boils down to this list. These are the evidence-based predictors of change. And the number 1 is actually number 1. The most important, is actually more important than any of the other 4 put together, is understanding and involving the customer. So in the system that you all work in that we're talking about here, the customer can mean a lot of different things, but what we talk about is the end user of services. So the customer would be the justice-involved person. And so really understanding what their needs and experience of the system is, feeling what the system, how it operates from the justice-involved person's perspective as opposed to from a staff person's perspective or from a systems designer perspective. is the most important thing. You have to really know what it's like to be the person that's using the services. And so that is the most important principle. If you want to change things or make improvements, you have to deeply understand both the person and their perspective, but also what their experience of your services are. And one of the things we have taught for many years now is that anyone that's thinking about doing a change should do what we call a walkthrough, which is to go through the service system exactly as the person who would normally go through it goes through it. And some things are easier to do than others with that, but I'll tell you, when we first started working with addiction treatment programs, what was sort of telling is how far different organizations were willing to go. Now, when Dave first was asked to work with addiction treatment programs, he didn't know anything about them, and so he decided to do a walkthrough, and he tried to, and this is, I don't know, probably 12 or 13 years ago now, and he's an older gentleman. He got himself admitted to detox for heroin addiction, and he actually went through the whole process of trying to get into services, and he spent the night. Now, he was not given detox medications because he didn't need them, but he actually experienced that process of what's it like to spend the night in a detox unit. And it's been interesting how few of us, the rest of us, are willing to actually go that far. I've only known a few treatment agency directors that have done something like spend the night in their residential program. But really, if you really want to know what it's like to be a justice-involved person, going from incarceration into the community and trying to access community services, actually doing that yourself and experiencing the barriers is the best way to find out what the barriers are that need to be addressed. So understanding and involving the customer is the most important principle. The second one is, and actually the rest of them aren't really in any kind of order. It's the order that I remember them in, but really the first one is the only one that is ordered that's the most important. The rest are all relatively equally important. So the second one is focusing on key problems, and the thing that we say is what keeps the CEO up at night. Or when I'm talking to CEOs, sometimes I say, what makes your staff crazy? Because they both are key they both will get you to focus on key problems. And a lot of times in a lot of public service sector systems, one of the key problems is, from the CEO's perspective, is money and time, and then from the both the customer perspective and from the line staff perspective is paperwork, and they're all related. And so a lot of organizations that we've worked with have focused on how do they reduce paper processes, how do they reduce the number of forms people have to fill out, the number of questions they're asked on forms, how many hands a particular form has to go through before it's approved, that kind of thing. So focusing on key problems, because if you focus on key problems that affect a lot of people and you solve problems that bother senior management as well as customers and line staff, then your solution is probably something that will stick. Selecting the right change agent, a lot of times organizations pick the person who has the right title, and they're not always the right person to be a change agent. So it's surprisingly important to have the right person doing the work. And when I say the right person, there are individual characteristics that seem to make for a good change agent. And a couple of those are optimism, being able to get along with a lot of people. Frequently in organizations, what I say to people is find the person that everyone follows even when you wish they wouldn't, because you want someone who's a natural leader that people trust and will follow anyway. So sense of humor is really important, and a real plus is if they know how to use data, although that can be taught. Some of the other things are harder to teach. So having the right change agent, the right person, you know, and it's always someone in middle management. Someone, you know, it's never the most senior people that are the actual person. Well, very rarely the most senior people that are the actual person trying to get change to happen. It gets assigned to somebody, and so thinking about who's the right person to assign that work to. Getting ideas from outside the field and outside the organization. This was actually a real revelation to me when I first became involved with NIATX, and it seems so obvious, but it isn't really. I think we look outside our organizations, but usually within the industry. And so, you know, you might, like if you're a state corrections person, you might look at what other states are doing, but you might not think, what does Walmart do that I can learn from? And but there are things that Walmart does, or McDonald's, or any other, or Apple, that they do that we can learn from. And one of the things we talk about is how, if you think about your problem in a bigger context. So the reentry problems are very frequently handoff problems, right? Person or papers. Some needs to get from one place to another, or from one service to another service. And we lose people in any handoff processes. So looking at what other organizations do handoffs, and you know, actually Walmart is a perfect example because they have this fantastic supply chain process where they are really able to track what's in the stores, and in their order system from their vendors is all automated. So we can't put RFID chips on people, but we could probably learn from Walmart how they do that handoff process between their various vendors to the various stores, et cetera, if we really examined it. So thinking not just outside of the organization, but from outside the field. What can we learn from other kinds of organizations? And I have found, since I've been working with NIATX, that this is something that I never used to do, and I do all the time. I go into, you know, whether it's a restaurant or a store, or I'm interacting with some kind of a business, a service business, and I think, you know, what are they doing really well that I can bring to my work? So, my computer just fell asleep. And finally, this one I think is the hardest for public service sector is rapid cycle testing. Figuring out how to scope a problem so that you can do rapid cycle testing. You know, we do a lot of talk about the Plan, Do, Study Act, or the Plan, Do, Check Act cycles, but what we really are talking about is how do you pilot test something in a really short period of time, really short. Like, can you do a pilot test in a few days and see how things work? And in big systems, in public sector, in healthcare, everything we do seems to be, every transition we have is a huge transition. You know, we adopt electronic medical records, or we change our philosophy, and so everything has to change. And what we're saying is that's rarely successful. Top-down, big things are rarely successful unless you can scope them in a way and pilot test in a very small way with a few people how to make things work, because then you can work out the bugs without affecting your whole system. And so that's one of the things that we have spent a lot of time working with organizations and systems, trying to figure out how do you do rapid cycle testing, and Sarah's going to talk about some of the difficulties we had with that in this project. We can go to the next slide. So I'm just going to do a quick example of a simple change project that had a big impact. That was from an addiction treatment program, Alpha Counseling, which is in South Carolina. So they wanted to increase the percent of criminal domestic violence referrals that actually became clients. They had a very low transition into being clients rate. And so they just tried a couple things. The first thing that they did was they started sending their staff to court to schedule appointments on site. So what was happening before is that people were getting a referral, so they were, someone was handing them a phone number, call this agency. And we all know that rarely works very well even for us. I mean, it's not even just for people involved in the justice system, it's for anybody. You get handed a phone number, very frequently people don't follow through on that. So they changed it. The first thing they did was they said, well, we'll just send people to court and we'll schedule the appointment with them while we're there. So they'll have an appointment already and they'll have a face. So they had a little bit of improvement for that. Then what they decided once they had done that and they saw that they got a little bit of improvement, they said, well, now that we're at the court already, what if we actually did that first appointment, that intake appointment, while we were there at court? And if we did that, then they would have the sort of the worst part of the process done, and then they could actually start services right away. And so just those two pilot tests, they went from an average of less than one person being admitted, one person in this particular population being admitted per month, to over 3 people being admitted per month. And you say, well, okay, you can look at this in different ways. They had over 300% improvement. You could look at it that way. You could say it's just a couple people per month. But a couple people per month adds up. And if you think about this in terms of, how many more people you're serving in a year, and then you think about revenue, and you think about not having clinicians sitting around doing nothing. I mean, a couple extra people per month actually has a pretty big impact. And you know that this was just a start, right? They kept working on trying to increase the transition rate. And now I don't know what the rate was. I don't know how many people they saw in court per month. That would be another interesting thing to see. But I don't have that information. Sarah, we can go to the next slide. So I want to end with the original 4 aims. I think one of the really good things that NIATX did that other kinds of process improvement models don't do is we made the how you pick your aims really simple. So if you've done TQM or if you've done Six Sigma, you'll know that a lot of the time and energy that goes into those kind of models is spent up front trying to figure out what the problem is. And we really said, no, the system has there's already been a bunch of research. We know what the problems are. We don't need to spend a lot of time focusing on that. Just pick one. Here's the 4. Just pick one. And I think, this is when we did the pilot, we really did use these, and I think they are relevant for the justice system and the transitions for reentry, although when Faye gets into it, I think how we measure them may be different than how we measure them in treatment, and there's a little bit more nuance possible. So here are the 4 aims: reducing wait times, reducing no-shows, increasing continuation, and increasing admissions. And they really sort of waterfall from each other. If you reduce wait times, you will reduce no-shows. So if you have high wait times, you will have high no-show rates. And so if you have high wait times, then that's the thing to focus on, and you will reduce no-shows. If you reduce no-shows, maybe it's obvious. It's obvious to me. Maybe it's not obvious to everyone. If you reduce no-shows, you will increase continuation. And if you increasing admissions actually doesn't flow from increasing continuation, but increasing numbers of admissions does flow from reducing wait times and reducing no-shows. But you can focus on any of the 4 of these, and it's sort of amazing the small things that organizations can do that will fix many of these problems. And a lot of agencies, from their experience, have started doing things like we don't schedule appointments anymore, just come in. Well, there's no wait time if you just come in. And there's no no-shows if you just come in. And it's sort of amazing. The other thing that people have done is, like if you look at continuation, well, if you offer services that people find useful, if you offer therapy groups that focus on things that people find useful, then they actually come back. And so people have done a lot of work around these particular aims, and I'm going to turn it back to Sarah to talk about the pilot project that we did from the pilot sites and the lessons that we learned, and then Faye's going to talk about how that affected our thoughts about measures.
Great. Thanks so much, Kim, for that wonderful overview. So as Kim said, I'm going to talk about the lessons learned from the 3 pilot sites, and that's actually part of the title of the paper that we're releasing, which there will be a link to in your chat box. We did a larger document, and then we also did a 4-page shorter summary document with just the takeaways from this. So this project actually started through these pilot sites in 2011, and the Council of State Governments Justice Center and NIATX partnered to release an application. So there was a competitive process for sites to apply to be part of this pilot sites. As part of it, they were given a technical assistance provider from the Justice Center and a NIATX change coach as well. So they had both staff from NIATX and the Justice Center helping them to work out these processes. The 3 sites that were selected is DeKalb County, Georgia, and it was the DeKalb County Sheriff's Office and the DeKalb County Community Service Board, who are the criminal justice programs and the court services that were the focus of the work in DeKalb. Durham County, North Carolina is the Division of Community Corrections, District 14, North Carolina Department of Public Safety, and the Durham County Criminal Justice Resource Center, that focus of that grant, and the state of Maryland. And the state of Maryland was the Department of Public Safety and Corrections, as well as the Alcohol and Drug Abuse Administration as part of the Department of Mental Health and Mental Hygiene. So the way that this was set up is each group identified 3 to 4 change projects that they wanted to pursue. And they tested these projects, and then they would decide whether they should adopt the change, adapt the change, or abandon the change. So just to have a few examples, in DeKalb, they wanted to increase the attendance at the first aftercare appointment. So in order to do that, they actually started to do family sessions with family members prior to release from jail that talked about what treatment was and what that looked like in the community to try to help increase that. So that's an example of a change that was adopted. In Durham County, they were working to reduce wait time between referral and intake appointments, and they actually they did replace the scheduled intakes with walk-in appointments, which is something that Kim mentioned as a potential thing. Another example from that site of something that a change that was abandoned that they didn't keep was they were trying to reduce no-shows and through telephone reminder calls prior to the appointment. They found that this really wasn't successful with the population because the population often didn't have phones that were accessible, or they would try to call and they were no longer in service, or they had switched numbers. So for the reentry population, they didn't find that to be a successful way of getting a hold of folks. And then in the state of Maryland, a lot of their work focused on larger systems level stuff around communication and exchange of information. So trying to include aftercare coordinators on email distribution lists if clients were referred to aftercare to make sure that linkage was being made. So these were really larger systems issues. And what in the state of Maryland, the project was focused on Baltimore, and there's a residential substance abuse treatment program within the facility there that was the focus of that. So trying to make sure that the RSAP program was having linkages to aftercare, so having that warm handoff to the community-based provider was the focus of that. So through work with these 3 pilot sites, we developed a series of lessons learned which we think are applicable to any site interested in going through change processes or just general information on reentry as well. So the recommendations that we came up with fell into 4 larger categories from the work with the sites. The first one is systems collaboration. The second is increasing communication and information sharing across the systems. The third is reduction of duplication of efforts and streamline of processes. And the fourth is on monitoring the process improvements and focus on data collection. So I'll go into each of these in a little bit more detail. When we're talking about collaboration across systems, the first recommendation that we were able to come up with is this joint participation from both the executive level and the frontline staff, which is really a key to implementing any of these changes to the processes. So it is great to have executive level buy-in, but you also need buy-in from the staff who are actually implementing the changes. So making sure that the change team is made up of both higher level staff members as well as lower level staff members, and this also goes back to Kim's point about selecting the right change leader as well. Timely access to treatment services is critical. So that one might seem a little bit like a no-brainer, but as you saw through Durham County moving to the walk-in appointments, they were having a 21-day gap in their referral processes previously, and through their change process, they were able to cut that to 7 days. So that is a huge difference that it made to their clients and to the retention in services that they had. Then also monitoring the client's participation can help them succeed in treatment, and then partnering with community corrections to coordinate post-release treatment. So this is, these two are pretty closely linked together because they're really both around the community-based providers being able to communicate with community corrections, or the jail treatment staff being able to communicate with community corrections. So making sure that the communication lines are open so that the community supervision agents are able to know if the folks are attending treatment, and they know when they should actually refer people to treatment. So in Maryland, there was an issue with the community supervision agents not being aware that an individual had been, in the residential treatment program within the prison and that they needed a referral. So one process that they did was adding a brightly colored piece of paper to the top of the paperwork packet that they were given. So that way they knew that, okay, this person with this brightly colored piece of paper needs to be referred to community-based treatment. So it gave them that extra reminder that that was one of the tasks that they would help with in order to make sure that case managers were alerted and that they were able to actually get those folks in community-based treatment. So a few opportunities to increase coordination that was found through these sites and through other work we've done is cross-training of staff. So when there was the availability to do training of staff to make sure everyone was on the same page, that's really helpful, as well as co-location of staff. So in one of the sites, they actually were able to locate someone to do screening and assessment within the community supervision office. So that was really helpful because they were able then to get screening and assessments done while the individual was meeting with their probation officer. just to emphasize, you know, this relationship between community supervision officers and the treatment providers really promoted treatment compliance. So enabling these two entities to partner together really was helpful to the person, so that way the right arm was talking to the left arm, and these two parties that were an integral part of their reentry were really communicating and encouraging them to go to their treatment and attend their appointments. So increasing communication and information sharing, having a shared language and clear terminology. So this is a huge issue when you're talking about systems collaboration. So when we're talking about the criminal justice system and the behavioral health system, it's often multiple systems within that as well. You know, there might be a different substance use and mental health provider, community corrections, and the jail staff might be totally separate. What we're talking about here is even simple things, like if you're talking about risk. So for example, in criminal justice, they could mean criminogenic risk, whereas in mental health, they might mean risk of self-harm. So just making sure that everyone's on the same page and talking about the same thing. Focusing on the customer. So this was actually a challenge for these sites, is who is the customer for this project. For the state of Maryland, they were focused more on systems level improvements rather than the person in the system as the main customer. So this issue, when we're talking about the criminal justice system, was an issue of focusing on the person in the justice system versus other people who interact with the system. Increasing communication across systems to increase timely access to treatment. So making sure that there is information being passed from the residential treatment provider to the community-based provider, making sure there's a warm handoff there is key. Also sharing information around release dates. So this is a big sticking point for a lot of reentry programs that we work for. If the community-based provider doesn't know when the individual is being released, it's hard for them to set up treatment appointments or even meet them at the doors in order to facilitate that engagement process within the community. Then a big takeaway from this is just trying to make information exchange easier. So how can we make it easier for all parties to be able to work together? The State of Maryland worked on a communication system so they could give access to community supervision agents of some information that they had from the facilities to make sure the information was exchanged and they had a full picture of their individual. Reduction of duplication of efforts and streamline of processes. So a big issue was when you're talking about eliminating a process, for example, in one site there was multiple screening and assessment processes being done both in the facility and as they reentered, through a case management program, and then also as they, again, were referred to a treatment provider. So in trying to eliminate the duplication of those screening and assessment tools, there was real fear from staff that a position would be eliminated. So being able to talk through that and explain that, there is a need for everyone involved in the process, but streamlining the processes and avoiding the duplication of effort make it better experience for the individual who's going through the system, but it will also make it better for staff because it will free up their time to do other things. Streamlining the referral process, so making sure that the referral process involved a warm handoff. In one of the sites, what they did was they worked to have the staff member from the treatment in the facility go to the first aftercare appointment, so that actually helped engage the individual in treatment because they already knew that person from when they were incarcerated, and they were able to then keep with the same person as their provider, help with that warm handoff. And then we already touched on the avoiding the duplication of effort. So one of the key pieces is that, when the referral process does go wrong and someone has to go through the processes again, and there are a lot of barriers already, the consequences are significant. If there's multiple steps before they even get an appointment or they're able to come and actually go to treatment, they're probably less likely to do so. Or if they have to go through 4 assessments before getting to the treatment provider in the community, that is more work for the individual and more work for the systems as well, and it increases the wait time for the individuals. So the last piece is monitoring process improvements and focusing on data. So with each of these change projects, there was the idea for the NIATX model is focus on one change at the time. And this was challenging for all the sites because once you have these ideas of changes you want to make, you have really great, excited groups, they want to do multiple projects at a time. But a key to the model is actually to do one project at a time, be able to test it, collect data, and then continue to the next change. So that way you can tell that that change is what is affecting the data, and it's not a combination of multiple things. Measuring the change project data was challenging for several of the sites, being able to actually get the hard numbers for what each of these things showed, whether it be the systems level changes or a smaller change So this issue with data collection led the advisory board to have a larger discussion on process improvement measures. And through this, we partnered with Faye Taxman to develop process improvements at the interface of behavioral health and criminal justice. So I'm going to turn it over to Faye to talk about that process. Faye, are you there?
Oh, yeah. Hi. Sorry. I was on mute. I'm here. Sorry. So good afternoon, everyone. I am now going to talk about more of a conceptual framework for thinking about process measures that can help us really get a gauge on how well the systems are functioning between criminal justice and behavioral health. So the next 15 or 20 minutes or so that I'm going to be speaking, this is developmental work that we've been working on with a work group that CSG put together and that Kim Johnson was involved in to really kind of think about how could we take the NIATX concepts and kind of overlay them in terms of the interface between criminal justice and behavioral health. All right, so as we know, the criminal justice system has a number of people who have a lot of health and social needs that are at higher prevalence than the general population. So this graph here basically illustrates that for those within the justice system, there's just a higher rate of substance use disorder, co-occurring disorders, mental health, tuberculosis, sexually transmitted infections, Hep C, and HIV. And this is of concern because we have a population that is served in the criminal justice system that does not have easy access to health care, and also some of these health disorders have an impact on their behavior, which may have a greater impact on how likely the person is to actually be successful within the criminal justice system. So the goal here is to really try and provide an interface between justice and health so that we can better serve this population to address some of these health needs. So the work group that was put together essentially decided that there was a need to really focus our attention on some guiding principles about what we're calling the interface measures. And these interface measures, again, are where the justice system and health systems coordinate and collaborate around access to and retention in health. So there are 5 basic principles that we identified. The first one is collaboration. So a general definition here is that it is not the fault of any one agency, criminal justice or behavioral health, in any given jurisdiction, that it's really the collaborative efforts of these organizations working together to ensure that there is treatment available for people involved in the justice system who have substance use disorder and mental health disorders, co-occurring substance use and mental health disorders. And so the notion here is that it is really the responsibility of these agencies to collaborate along the goals of increasing access to care and making sure there's the appropriate type of care. The second goal is that the organization should work together to jointly facilitate access and retention in behavioral health services, and that the CJ and behavioral health partners, it's essential for them to be concerned about the behavioral health outcomes for people involved in the justice system. So instead of talking about warm handoffs or cold handoffs or some handoffs from one system to the next, the notion here is that it is the joint responsibility and that agencies need to find better ways to really work together to facilitate this access and retention and care. The third notion is that there should be options for care. And the concept here is that not every person in the justice system, even though they may have many different needs the same type of treatment program. And so we have to make sure that the justice system has an appropriate level of care to meet the varying needs of clients within the system. Therefore, it's not behooving us to see a system that only has, some programming that's very limited dosage, that there may be a need to actually have more varieties of programs of varying dosage. The fourth measure has to do with process improvement measurement. And here we basically, and we're going to talk through some of these ideas, but here we basically suggest that the systems, in order to know whether or not they're collaborating well, whether they're accessing and retaining clients in care, that they need to be able to put in place a series of measurements to allow them to assess whether or not they're meeting their goals regarding access, retention, and completion in care. And these process measures, are basically from the notion that what gets identified gets measured, and so we want to make sure that there are appropriate measures in place so systems can have measurements that they can use to determine how well they're doing. And finally, the last point has to do with quality and joint accountability. And here the notions are that process measures can promote quality and joint accountability in the delivery of substance use and mental health services. So again, we need quality measures to tell us how well our systems are working, and we need measures of joint accountability. So this is the basic guiding principles, and again, this was to ensure that it's clear that these interface measures have to do with what the justice system does as well as what the behavioral health agencies do, and actually the goal here is to really focus on the interface between the two systems. So this is a graphical depiction of basically the infamous sequential intercept model, where the goal is basically to identify where the client is, whether they're on the street, whether they're arrested for an offense, whether they're in jail, prison, or on probation or parole or pretrial services, and to really develop the interface with the treatment system through screening, assessment, referral, placement, initiation, engagement, retention, and completion. And when we talk about interface here, it doesn't matter where the client is. What we're really talking about is the interface between clients in the various settings of the justice system and the different components of treatment and care. So there are 4 types of process measures that we want to propose, and we hypothesize that essentially if organizations could put these 4 measures into place, that they would be able to view how well their system is doing and how accountable is their system. So the first set is about, as you would imagine, about identification and referral systems. And we want to know basically how well does the system do at facilitating interface with the treatment system. The second is engagement and completion. And here we want to know what impact does participation in justice and health have on clients accessing care and how well they do in care. The third part is recovery management. Since addiction, as we know, is a relapsing chronic disease, it's important for people to be involved in ongoing treatment, and we want to know how well is the client in managing their own care and their recovery. And then the final set of process measures has to do with access and systematic responsivity at the system level. In other words, it is the responsibility of justice and health systems within a particular jurisdiction to make sure they have the appropriate type of care available for clients. And so we want to know how well does the system do at providing access to these appropriate types of care. So what I'm now going to do is kind of go into more detail. Sorry, I'm a detail person here, but go into more detail to really get a sense of what are the types of measures we're talking about. So for the identification and referral set, so this is at the system levels, we're interested in the following. So we're interested in the screening rate that occurs. In other words, regardless of where the person is in the justice system, what percentage of people are screened screen positive for behavioral health issues using a validated screening tool. So as you can see in this graphic here, it's clear that in this particular setting, where you have more rows devoted to probationers and parolees than you do arrestees, or people who are in pretrial status, or people who are incarcerated, that the probation system has a greater screening rate. And this is important because this basically is the starting point for the justice system to identify potential people that may need care. Now, we know that screening is basically just an opportunity to identify a potential target population. And so the next measure is clinical assessment rate. And here we're looking at the percentage of the clients who are clinically assessed using a validated assessment procedure as needing behavioral health services. So this then becomes our population, really, that we're talking about in terms of those that need access to care. The third category is referral rate. And as you can imagine, the referral rate has to do with the percentage of clients who are screened or assessed for a behavioral health disorder that are actually referred to a treatment program or linked to care. And so the goal here in the referral rate is to really see what percentage of the clients that are actually being targeted for care or should be targeted for care are actually being referred or linked for a particular program. Another area of interest is the percentage of people who are referred to behavioral health services that actually start the services within 14 days of screening or clinical assessment. So the 14 days was actually adapted from the Washington Circle, which is a think tank group that really talked about good quality substance abuse treatment services. and they found that clients who initiate care within 14 days, those clients basically, that's a better success rate of people being early adopters for engaging in treatment through their initiation patterns. So we wanted to be able to capture how much of the referrals are actually mean that the client is getting into the front door. And you can imagine let's take a probation environment, you know, if probation officers may not encourage people to meet their treatment conditions, it could be 3 or 6 months before the client actually tries to access care. And so this particular measure would tell us what percentage of the probationers are actually accessing care within a very short period of time. Okay, so that's our first set of measures. Whoops, sorry. The second set of measures have to do with engagement in care and completion, and this is at the client level. All right, so engagement, again borrowing from the Washington Circle, has to do with clients who participate in at least 2 treatment sessions within a 30-day period of initiation. Again, we're trying to identify the cohort of people within a particular setting that actually are engaged in care. And so we're looking at the initiation point and 30 days later, and using that as a way of getting a sense for, you know, how many of the clients are coming back for treatment. And then the other 2 client-level measures are retention and completion. So we all know that, you know, showing up for life is the most important thing in terms of trying to get better outcomes. So retention here has to do with length of stay in treatment for different levels of care, and completion has to do with the percentage of people who successfully complete treatment. And those are measured, again, at the individual levels to give us indicators of how well our programs are working. The third set has to do with recovery management, which, again, given the chronic relapsing nature of the disorder, being in recovery means managing recovery. And so we've basically looked at this notion of a continuum of care, which is transitioning people from the first treatment to a second treatment, so like a step-down program or aftercare program, or potentially even transitioning people from substance abuse treatment programs into employment or educational programs. But the notion is you're trying to engage people in active pro-social activities that are attended to reducing their criminogenic needs and reducing their behavioral health risk disorders. Okay, and the last part has to do at a systems level, and this is really looking at issues about access measures in terms of access to care, and then this notion of systematic responsivity, which is basically to ask the question, is your jurisdiction positioned to provide the right type of treatment based upon the needs of the clientele? So the first, as we all are well aware of, the first issue has to do with insurance enrollment, and this has to do what is the percentage of individuals involved in the justice system who are enrolled in health care. As we all know, with the changes in our health care system, you know, we have a great opportunity here to expand the number and type of treatment services available. So capturing the health insurance enrollment rate is a good way to begin to look at your system. Another way is a tool that my team at George Mason University has developed called the R&R simulation tool. And this particular tool is about matching the client's level needs to the actual programs and services. So the first aspect here is to be able to identify what are the needs of the population. So we know that people who are involved in the justice system have a wide variety of needs. In this graphic depiction, you can see that this sample of probationers have a number of needs, with around 72% having employment needs, 69% having family needs, and about 36% having serious mental health disorders. So first we have to understand the needs of a population. And here, this is a similar graph that basically suggests that sometimes the general population, which was the first graph I showed you, sometimes subpopulations like females are different in terms of their distribution of needs. And so we have to make sure we have the right type and level of services available. Using our R&R simulation tool, you can do a distribution of the types of programs in your system. So again, this is a hypothetical jurisdiction where they have 6 life skill programs, 4 self-improvement programs, and 3 drug treatment programs primarily dealing with substance use disorders. What we do is we combine, and the tool allows you to do this, and if you're interested in more information about this, in order to look at your own jurisdictions, feel free to contact me. But what we do is we combine the probationer or the client level data with the program level data to get a gap analysis of what are the gaps of service in your particular jurisdiction. So in this particular jurisdiction where the purple and the teal converge, like in Group A, the system has good capacity to serve the clientele. But in Group B, which deals with antisocial cognitions and values, it does not. There's a tremendous gap in services, and in Group C, which is self-improvement, there's a small gap in services. So what this tells you is if a jurisdiction was going to add some new services, they would add those services in terms of Group B because that's where they have truer deficits. They could also add some in Group C and D, but clearly criminal thinking and criminal cognitions is an area that jurisdiction needs more attention. You can also do this gap analysis by gender. So you see for females, there's a different gap analysis than there was for the general population. And the same thing for young adults. So here we were looking at clients who were 18 to 27, and we found that, they had lower rates of substance dependence than the general population, but they had very high rates of criminal thinking, which resulted in a greater gap. So in conclusion, I want to basically ask the question, why do we need process measures at this interface? What is it we're trying to accomplish? So if you think about what Kim has mentioned in terms of what NIATX has done for the substance abuse field and for other systems overall, is NIATX has given some good benchmarks and then processes by which people can make improvements in the systems of care to really help clients. And then, Sarah outlined the pilot in 3 jurisdictions applying the NIATX model. And, that pilot suggested that the 4 benchmarks of NIATX are useful, but there may be other components. And so this process measure piece was designed around trying to identify other components that would be really helpful in improving systems. So why do we need process measures? We need them to hold systems accountable so that we know where there are gaps in services and procedures, whether it's at screening or referral or getting people insurance. We know that some of these measures can be used as warning signs. They can tell us really how likely are we to be having an impact. And so, for example, Deborah Garnick has identified that engagement predicts reduction and rearrest. So if we can engage people, they attend 2 or more treatment sessions after they initiate care, we can reduce recidivism rates. And we have a large variety of research literature that talks about how important it is to complete treatment, and treatment can also produce reductions in recidivism. So essentially, these process measures are designed to really supplement, individual level measures so that we can basically see what types of systems do we need to improve to get the desired outcomes that we're interested in. All right, so I am going to turn this back over to Sarah, and let me know if you have any questions.
Thank you so much, Faye. So we did have one question, which was, will there be access to the presentations following the webinar? And the answer to that is yes. We'll post a copy of the webinar recording as well as the webinar slides on our website. So we're actually going to open the line to any questions you might have about the pilot sites, about NIATX, or about the process measures. Alternatively, you can also, there's a chat box on your screen, and you can feel free to type the questions into the chat box too.
Yeah.
Okay, one question that came in, this one's particularly related to the process measures, is so when you're thinking about using these process measures, is it okay to select a couple for a jurisdiction, or do you recommend using all of the measures?
Well, I would think that it would be beneficial to select a couple in each of the categories so that you get a better sense of your system overall. We understand this is a lot to actually pull together, but I would think that you would really want, a jurisdiction would really want to see these issues about, referral process, screening and referral, issues regarding engagement, particularly based upon, this notion that engagement is a precursor for positive outcomes, and issues regarding the whole systemic responsivity to make sure that you have the right types of programs and services. But, so I think picking a couple from each of those categories is a good way to begin.
So can I add to that too, Sarah? It's really important to look at multiple measures to figure out where your strengths are and where your weaknesses are, right? But then once you figure that out by looking at those measures, I would then recommend, if you're thinking about what you want to improve, pick one thing to start with, because it's just easier to focus in one place. And you want to keep measuring the things that you're measuring because they all impact each other, and you'll see improvement or not. I mean, sometimes things you do improve in one place and they have a negative impact in another place. So then you have to figure out what to do with that. But when you're focused on trying to accomplish something and make a particular change, it's better to be very focused. But you have to look at everything to know where you want to focus, if that makes sense.
Great, thank you, Kim and Faye. So we have another question in the chat box, and it is, how do smaller areas working with limited resources and treatment options, look at doing one of these processes?
Faye, I don't know if you want to say anything. I don't think size matters. I think there are opportunities for any size system or any size even individual organization to do improvement, and it doesn't necessarily require a lot of resources. The primary resource is creativity. and a little bit of time to think. But so I don't know that, I mean, we've worked with state-level systems. We've worked with, one-person agencies, and we've worked with everything in between. So I don't know if that answers the question, but I don't think the size matters. I think pick something that, look at your data, pick something that needs improvement, and start figuring out those incremental steps to work on it.
I'd like to add to that. I agree with Kim. Size doesn't matter. And I think the other part of the question was, in jurisdictions that have limited treatment services. So one of the big opportunities here is to really ask this question, what is the variety of services we would like to have? And to get your partners together, to get everyone to basically buy in that there may be a need for expanding the services that are provided within your jurisdiction, even with the limited resources people may have. I mean, one advantage of ACA or the, insurance opportunities, health insurance opportunities, is that there is a potential for getting another funding sources for a variety of different types of programs. But first, everyone has to be convinced that there is a need to expand the programs that exist to match the needs of the clientele. So using this process, and particularly looking at some of the systemic responsivity framework, you can actually get your team to agree to, if someone came to us and said, here's $50,000, what can you do with it? You'd be able to have a list of what do I need to grow. So, part of this effort here in any team collaboration effort is to really kind of develop that joint mission and joint perspective on what are the changes that are needed in our particular program of services.
Yeah, and I think the key piece of part of what we're talking about in this project is the cross-systems collaboration piece and being able to look at things and measure things, not just what are they doing in a jail or prison facility or what are they doing in community, but what are they able to do across both. So really making sure those partnerships are strong. And that also gives you the ability to have multiple stakeholders from different systems buying into it, especially in a jurisdiction with limited resources. That can be very critical to be able to partner and use parts of your resources, a joint staff position, for example, for a case manager in a jail facility doesn't necessarily have to fully be funded by the Sheriff's Department. It could also be funded by community-based treatment or other sources. So I think the cross-systems piece and engaging folks within a smaller jurisdiction with limited resources is a key part. Okay, we have another question. This is specifically a question about the Maryland pilot site. This individual is asking, was there an economic impact and did it require additional funding? So as far as we know, they didn't do an evaluation on whether there was an economic impact for this change project. So as far as we know, they didn't test that piece. That wasn't a part of the data they were collecting. So we can't really answer that piece.
Is there anyone from Maryland on the call? I see DeKalb is on the call. I can't tell if anyone from Maryland is on. Guess not.
Yeah, so unfortunately, as far as we know, they didn't actually measure the monetary or economic impact of the change processes they made. But their processes were at a larger system level, so mostly, so they would have affected more than one individual. It would have been a larger impact since they were talking about a state system. Okay, if there are any additional questions, please type them into the chat box.
So I guess maybe I could ask a question. So I would be interested if any of the attendees think that they would have any data available in their jurisdictions to be able to measure these process measures. We're actually, thinking that, in management information systems that are maintained by either justice organizations and or health organizations, this would be the best way to really develop these measures so that they could be, part of a management report. So does anyone from their own jurisdiction think that they have that kind of data available?
Okay, so we're going to set up a polling question that has that information in it, because a lot of folks are watching from their computer, so while they can type into the chat box, they may not be able to verbally answer.
Oh, okay, sorry.
So as we get that poll together, let me ask Kim a question. So Kim, in your experience of working, this cross-system of criminal justice and behavioral health versus working with other systems, are there any, specific things that stood out for you that made this cross-system collaboration different from other change projects?
I think any cross-system collaboration is harder than any sort of within one organization. Because there are more players. So I wouldn't say, I did another project that was a cross-system where we were actually trying to get prevention programs into rural communities. Prevention not being substance use, but for older people. So we're trying to get health promotion or prevention programs, like a falls prevention program for older people in communities, and it involved multiple systems like this did, and I would say both of those efforts were equally complicated, just because you have every organization that's involved in the process has their own processes internally, and we all want everybody else to change, right? We don't want to change ourselves. And so there's this step that's sort of an extra step in trying to get people together to have the conversation about what each of us needs to do differently. And so it is harder. But I wouldn't say it's necessarily different from other kinds of cross-system changes.
Thanks, Kim. We were able to get a poll up asking about, does your jurisdiction have the information to begin to collect some of these process measures? So if you can just answer the poll, it should be appearing on your screen. We have yes, no, and unsure as the potential answers here. We'll just give it a few seconds to get some more folks to answer. So on your screen, you should see the question.
Sarah, while people are doing that, I kind of want to go back to the last audience member question, which was about the small system and that's under-resourced. And I think you can use those tools to say, well, what do we have and what don't we have? But sometimes you have capacity that you don't know that you have, and that's one of the things to try to figure out as you're identifying solutions. So you may not have a particular service, but you may actually have a treatment agency that has a person that has the skills to provide that service, and they may be able to do that without additional funds, depending on what their existing capacity is. And one of the things that's really interesting to me in these systems, but in the behavioral health system side of it in particular, is, we still, even after doing this work for 10 years, there's still a lot of unused capacity in the system. So if you have no-show rates of 50%, and there's still that's still out there quite a bit, you have a bunch of capacity that's not used, although it feels like it's being used. And so it's one thing to consider when you're in an under-resourced part of the country or an under-resourced organization is how are we using the resources we have, and can we think about how we do things differently to use those resources better. And that's a very engineering way of thinking.
Thanks, Kim. So we've had about a third of participants complete the poll. So if anyone else wants to answer it, we'll give you 5 more seconds to do so. Then we'll post the results. Okay, so we're just in the process of posting the results from the poll right now. So it looks like most of the participants that were able to respond to the poll weren't sure whether their jurisdictions would be able to collect some of this information, but there was 4 sites who indicated that they were sure that they would, and no sites indicated that they wouldn't be able to collect this data. So it sounds like a lot of folks would need to do some discussions with other agencies and figure out whether it would be feasible to collect some of these measures.
Or maybe they can collect some, but they're not sure about all.
Or maybe they know what they can do on their side, but they're unsure about the treatment side, because these measures require sort of the ability to do it, joining databases.
Right.
But, I mean, that's more positive than I actually thought that people would, be aware of. So, and I'm sure many of those unsures will turn into yeses with a little digging. So that's, I think, pretty positive.
Yes, that's definitely very positive. So we didn't have any additional questions. So Faye or Kim, did you have any closing thoughts or remarks that you wanted to say?
This is Faye. So I just I wanted to basically, reiterate that, the reason that we came up with this idea about doing process measures is that in so many other disciplines, and particularly in the healthcare industry, there usually is a core set of quality measures that are discussed. And, I come from a criminal justice background. I've worked in the field for a long time. And, we don't necessarily have the same proximal kind of process measures that we can look at and think about how our systems work. So in this great time in which we're thinking about reforming systems and making great changes, I hope people will consider this as a potential way of kind of checking in on how well are we doing and where do we need to make systems improvement. And I'd encourage people to contact Kim and Sarah, whose organizations both work with organizations to really help develop these interagency efforts focused on quality improvement.
Thanks so much. Thanks so much for that, those eloquent final remarks, Faye. I just, again, want to thank Kim and Faye. It's really been a pleasure collaborating with NIATX and George Mason University on this, and we'd also like to, again, thank the Department of Justice, Bureau of Justice Assistance for their collaboration and funding on this effort, and specifically Danica Binkley for her support of this project, and Maria Fryer. So thank you so much, and the products are now available on the website. You'll be able to download 2 longer papers in addition to 2 shorter documents. For the pilot studies paper, the lessons learned document, in addition to the longer document, there's a 4-page summary that just goes over some of the key points that were highlighted through the PowerPoint slides. And for the process measures, we have a 3-page document that has measures itself, and then we have a longer paper that explains the measures and gives examples of how to use them. So we look forward to having you access those products, and if you have any questions, please feel free to contact any of us. Thank you so much, and have a great afternoon.
Thanks, everyone.
Bye.
Bye.
Bye.